Hello, good evening, everyone. I think we'll get our evening sessions started. I turn you over po to the session chair of the next session, Dr. Eric Tayag.
Hello, good afternoon, everyone. This is Plenary 10, and we're going to start with effective risk communication during the COVID-19 pandemic. Have you ever wondered, participants and delegates to this convention, that despite our pleadings, many people still don't wear masks? And now, the controversy regarding the COVID-19 vaccine, despite the science that may affect its use and its potential benefit, people still hesitate to get a vaccine at some future time. Can risk communication change what we have right now? Okay. Let me now introduce to you our speaker. Okay. We have Dr. Michael Tan from the University of the Philippines. I have known him personally as he earned his Doctor of Veterinary Medicine from the University of the Philippines in 1977, a Master of Arts in Anthropology from the Texas A&M University in 1982, and a doctoral degree in Anthropology from the Medical Anthropology Unit, the Faculty of Social and Political Science, the University of Amsterdam, the Netherlands. He was the 10th Chancellor, University of the Philippines Diliman, Quezon City, the Dean and Professor 7, College of Social Sciences and Philosophy, UP Diliman. He is a recipient of numerous awards, the most recent of which are Best Column on Children from the United Nations Children's Fund in 2005 and the Philippine Press Institute in 2006. The Rizal Outstanding Chinese Filipino Award for Literature and Journalism. Ladies and gentlemen, for the topic, effective risk communication during a pandemic, let us welcome Professor Dr. Michael Tan. Professor, thank you and welcome.
I feel so clumsy sometimes. I'm not as young as I look, no? But I try to keep up.
You're doing all right. The,
Okay.
the the
Yeah.
slide is now on the screen, Professor.
Thank you. No? So let me start off with the clarification because there are risk communications is usually the domain of mass communications practitioners, no? And the fact is, of course, we work closely with them. No? But I come in from anthropology, and I appreciated the invitation. I thought it might be good if I speak as an anthropologist that gives inputs, no, to the different health groups. No? I have given inputs to the health department, to medical city, to various health groups. No? And our ang kalakasan ng anthropology is we are in touch with what is called popular culture. No, it's just a fancy term for the man, the woman on the street. No, we're constantly watching people, no? And we look for people's perceptions, their behavior, their resistance, as well as change. No? Because people do change all of these things. And I will of course be discussing mainly COVID-19 and the need for risk communications. No? I wanted to remind our distinguished doctors here that there's a difference between hazards and risks. No, hazards are natural disasters. No, what insurance companies call and we have to live with it. And unfortunately, the Philippines is one of the most disaster-prone countries in the world. No? Lahat na lang nandito, no? Including pandemics. No? But risk is another term. Risk and vulnerabilities, depending on what humans do, we can increase the risk or we can mitigate it, we can reduce it. No? And we talk also about risk at the individual level, at the group level, and many other formations there, social formations. No? And we, of course, want to connect this now to COVID-19 and the specifics about COVID-19 that we need to keep in mind, and which PSMID play, where you have to play such an important role for such a difficult topic because it is new. 2019 lang, late 2019. And there's still so much that is unknown, including the virus itself. Where did it start? I think you've been following the news, no? The reports from Italy and from the States are very intriguing, no? And we know it's also heavily politicized. No? What is this variant 614G, no, for SARS-CoV-2, which has been reported in the Philippines? No? Fortunately, it has not caused panic in the Philippines, but it is important for infectious disease specialists to keep track of what's coming out about this variant. Much remains unknown about the illness itself. It started out, mainly people looked at this as a respiratory disease. But in the months that have passed with millions now of patients, we know that it is multi-organ and involves raging, I'm being dramatic, raging inflammation with the equally dramatic term cytokine storms. No? And now beginning to emerge are long COVID or long haulers, no? People who supposedly have recovered but are still suffering from fatigue, brain fog, and multi-organ dysfunctions. And I really want to push PSMID to try to speak out more on long haulers. And I don't want to go into details, no, but we know that there are some very disturbing reports coming out, especially because mental health is involved. No? And what about transmission? That, of course, is the most difficult that we have to deal with. No? We had the paranoia over transmission by fomites, no? Which of course benefited SM and all the other malls. They were selling everything, no? all the way up to ultraviolet light, no? And everyone was disinfecting everything. No? And I say it's paranoia, and I think it was overblown, and US CDC has been trying to tone it down. But we're still at that stage of panic. No? And alam mo, 2 beses na akong kamuntik na nadulas sa mga foot baths na yan. No? And then the guards are always so apologetic and say, opo, marami ng matanda na nadulas dito. And then I said, ba't ayaw ninyong tanggalin? Kasi sabi ng boss, kailangan. Ano? Really, the foot baths are useless. I wish you would speak out about this. No? We're going to have hip fractures one of these days. No? And then the scare with ophthalmologists, no? Can it be transmitted through the eyes? Hypothetically, yes. No? But we know that the scare has sort of toned down. And I don't know how many of you read the Chinese research on fecal plumes, no? Na, because it's also found the feces, no? And the warning was a bit amusing, that when you flush the toilet, may pluma yan, no? Parang sa Taal volcano nga when it erupted. And so the advice there was you close the toilet lid when you flush. No? And it passed. No? I don't think it's a big deal right now, but people, you might want to keep it in mind. And we know amid the pandemic, our problem is the infodemic. No? Social media and the internet has meant infodemics, plural, no? Including, of course, our political leaders like Trump and Brazil's Bolsonaro. They're the most famous here. No? But I don't know if you have been getting it. There's Nick Perlas, who is active in the environmental movement, has been passing around, his blog has been going around. He's saying that this is all an info scam, that that COVID-19 is not as serious as you want to think of. I hope you can take time to read it, no? Because there are people who are starting to ask me what I think. No? And I think it is all misinterpretation, and social media is propagating it. No? And then we know that traditional media continues to be either an ally or an obstacle. No? And the fact is, traditional media, especially today, because of the competition with social media, they need to sell news, and they do this by selling bad news. No? And then, of course, we know traditional media also is now emasculated. It's so hard to get information when you need it. No, this is not for ABS. We have to live with the fact that ABS-CBN, people depended on ABS-CBN, no? And now they're limited to a Facebook site, no? And an app. No? And then, of course, in comes the medical professions. No, unfortunately, medical professions have sometimes aggravated the situation with outright misinformation. Trump's own medical advisor, Dr. Scott Atlas, who is a neuroradiologist, no, but who was spreading all these things about trying to downplay the severity of the pandemic, that masks are useless, physical distancing is not helpful. He resigned recently, thank heavens. No, but not without inflicting so much damage. Nakakaawa talaga ang America, no, with Trump and Atlas. No? And then, let's face it, messages and statements are sometimes vague or late or nothing comes out. No? I'll get back to this point later. So effective communications, my presentation will talk about who and how to reach, no? What messages to use, and the whys behind the messages, and the when. No? Kung sa reseta nga, there's always a dose. We need also to know how often we should get messages through. No? Okay, let's start with the who. No? I think we have to prioritize and get to vulnerable populations, young people in particular, those who continue to be sequestered, recognize the very high frustration levels of these sequestered adolescents, which means kung makakatakas sila, magwawala yan. No? And young people tend to think they're invincible. No? So let's watch out and try to get to young people. The elderly, including Mike Tan, no? Also very high frustration levels because we're supposed not to go out. Of course, because I'm still working, I can use that as an excuse. No? But among other elderly people, I see a lot of helplessness and hopelessness, no? And hunger for news. No? I want to emphasize the urban poor. I get the epidemiological figures every day from the DOH, no? And I'm shocked with some of the figures there. There are barangays with infection rates ranging from 600 to 900 per 100,000. The national rate is about 400. No? I actually did the numbers there. Okay, Quezon City is particularly problematic with the urban poor communities. Then you have the frontliners. I think you are aware that there are so many outbreaks among the military and the police because they are part of the frontliners. No? And security guards are often neglected too. And then, of course, our health professionals. Then we need to get to the gatekeeper populations, people who decide what information to spread out. No? And for instance, in families and communities, it's the women when it comes to healthcare. So we need to get more to women's groups. No? The barangay health workers, I feel, are not being given adequate information. No? And key national and local government leaders. No? And let's not forget the educators. No? There's such a crying need for teachers to integrate COVID-19 education into all the subjects, no? Science and pati math, no? Pwedeng pasok din sa math dito, no? Okay. And as an anthropologist, I always say, look at the signs of the times, no? Baka hindi nyo makita masyado. This was taken April in Zabarte, Caloocan, no? There was a pure gold sign there, safety advisories, no? And down there, hindi mo makita. No? They actually say they take vitamins rich in zinc. So hinalo nga ang minerals and vitamins. No? And then next to the pure gold was a drugstore. And this is not the first time, no? But to see this, but the drugstore had assigned their no stocks. And everything, all the vitamins were, wala silang stocks. No? So, I did ask them if they had zinc and they didn't know what that was. No? I said, oh, doon no sa pure gold tarp, no, meron. And they said, ay, hindi namin alam ko ano yan. Actually, they put their Conzace, one of their products, wala na rin ano. No? Anyway, my point is that we did have a shortage of vitamins for the longest time ever. No? And you as doctors know that it's a bit, you will have to deal with this. People will always ask you, no, about vitamins. And I don't know what your view is there. No? But my doctor friends usually do not. We'll get back to that later. No? Okay, so fine-tuning the who. Be aware that there are health cultures, plural, no? And people are already doing things on their own, learning things, then providing advice. No? The health cultures are embedded in broader cultures. No? For instance, among the ethnic Chinese, hindi ko pinasok, no? There's a particular drug called Lianhua Qingwen, which has been approved by FDA, but it's very interesting. The approval was a there's no mention of COVID-19. Instead, it talks about dispelling the heat, and which is traditional Chinese medicine language. And in ongoing research in UP, we have researchers in Muslim areas. Apparently, black seed has become very popular. I never heard of this. It's Nigella sativa or black caraway. It's imported from the Middle East. So, ang punto ko lang dito is we need to know what people are using out there, and PSMID needs to speak out when we are dealing with the aspects of infectious diseases. Okay, then we need to link the who to the how to reach people. And of course, we talk about mass media, including social media, posters and friends in broadcast media, interpersonal media, one-on-one. How are you going to tap into telemedicine, the HMO and satellite clinics? I did visit your site. You have those excellent algorithms, but the algorithms definitely will not be understandable by lay people. And I know you were not aiming to reach lay people. Okay, let's get to the second part of my presentation. It's the what, the messaging. What should go into messaging? And I feel we need to tap into health psychology research. There are tons and tons of materials out there. It's not developed in the Philippines, and I wish that UP can move into health psych, not just UP Ateneo. I don't want to play favorites, right? And one of the important things that we have to learn there is that fear and threats and intimidation and scolding only has short-term effects. It works, but only for a short term, and sometimes leads to paralysis. Because if you scare people, sometimes, for example, using war metaphors, there are journal articles on this. If you compare it to war, sometimes people will say, "Gosh, it's so hard, hindi natin kaya." Or you can have, if you keep threatening people, it can lead to denial. They'll say, like in HIV/AIDS, at one time the way it was being, the health messages were making people say, ay, hindi naman ako ganun, hindi naman ako malandi or malibog, so hindi ako susceptible. Or young people say, ay, ako malakas. As an anthropologist, I can tell you that the notion of hawa is constantly being balanced with the notion of resistensya. And many people will go into denial saying, malakas ang resistance ko kasi nagba-vitamins ako, kasi bata ako, etc. Okay, we come to the pasaway dilemma. And I would really urge we stop scolding people about being pasaway. We actually have high compliance, especially if we compare ourselves to the Americans. They are really at the bottom of the list with mass compliance and physical distancing. I just had to share this picture. Recently in the New York Times, they reported on the police having to break a party in a mansion in Long Island. 400 people were partying. Talk about pasaway. And the New York Times article said that every weekend, the New York police have to crack down on some big party in the metropolitan New York area. Okay, yes, there is pasaway, but let's try to understand why there is pasaway. And again, it's misinformation, disinformation, or no information. We have to look at cognitive dissonance, what's being said versus what's being done, especially those with power, like the Long Island mansion. People are looking and say, oh, if you're rich, then you can do that. And look, they don't get to trouble. In the Philippine context, let's also be careful. I'm getting more and more reports from our informants that the police are taking bribes. So the thing here about mass use is they say, kaya naman. And the mass use penalties are very high. But they're thinking, ay, kaya naman pag merienda na lang, tatahimik na lang police or whoever is trying to enforce the law. Okay, and we really have to move beyond bawal. This is a poster, bawal ang walang face mask. And look at the multa, 5,000 pesos for the third offense. Actually, it's 1,000 for the first offense. Panakot yung 5,000. Sige lang, I can live with that. And then obserbahan ang social distancing, 2 meters or 6 feet. This is also so problematic because you have people saying 1 meter, 2 meters, and I think PSMID has to come out and explain that the 1 meter is the minimum, and 2 meters might be better. We're simply, the numbers have to. But more interesting is that just this morning I conducted an FGD, and most of the participants could not demonstrate what 1 meter is. hindi pa wala pa yan sa popular culture natin. So they depend daw on the markings in the malls, no? But no, the idea of 1 meter is difficult to visualize. No? So cognitive models in health psychology for behavior change are proving to be more effective than scare tactics. No? And what are the cognitive models? People need to know the options. No? If you limit it to bawal at mamumultahan ka, wala nang ibang options. But if you tell people what they can do instead, and if you can convince people kaya nila ito, the likelihood of doing something rises. No? So with masks, for example, give the options of different kinds of face coverings. No? All the way up to kung wala kang dala, wala ka ng ibang paraan, sige, use your t-shirt, use your hanky. No? But for us to be to insist that you have to use only N93, no, really limits people's options. No? We know that already. That's very clear. No? And then there's the importance of positive reinforcement. No? And I like this. This was a tarp right next to the other one na bawal ang walang nakamask. And I thought it was so much better to say ugaliing magsuot ng face mask. No? And then of course the next question is how do you make it an ugali? And that is a real concern. No? Ako hanggang ngayon, minsan lalabas na ako nasa kotse and I say, oops, nakalimutan ko naman ang mask. No? But we really have to make it a habit. No? I also like their slogans at the bottom: mask ligtas, mask protectado, mask sigurado. No? It's a very positive message. No? We need to be more positive. No? And then we have to emphasize that science is self-correcting. It is actually non-absolute, and that we are constantly discovering new things. No? Because the anti the blogs that have been attacking COVID-19 as a scam, no? Keep saying that, look at the doctors, no? They keep changing their messages. No? But it shows they do not understand science. Science is self-correcting. No? It is not theology, no? With dogmas and absolutes. No? So we have to keep emphasizing that, and that we are still discovering new things about COVID-19. No? I would advise we pick words carefully. No? Physical distancing, at least 1 meter. No? What is at least? What is 1 meter? Kailangan magtagalog na tayo dito. Give other measures that people can relate to. No? I forgot to insert here, no? Like the variant I used earlier. No? I mentioned the variant. Do not use the word mutant. No? Ang mutant kasi, no, just look at ano bang iniisip ng tao pag mutant? Zombies, right? Ang daming zombie ngayon sa Netflix. And we have to talk about variants. Let's not scare people to death. No? And then I think very problematic is the term nasa hangin. No? It's a translation of airborne. But airborne is not nasa hangin. No? When you say hangin, ang iniisip ng mga tao, outdoors. No? And they think that the highest risk for COVID-19 are outdoors. So they feel very safe indoors, not realizing their highest risk is actually indoors. No? So iwasan natin ang paggamit ng nasa hangin. No? Okay. There's also the importance of mnemonics. No? Kayong mga doktor, when you were in medical school, you had all these mnemonics to memorize, right? And keywords. No? And many governments are playing on this. No? The Germans had their AHA, which were the German words for physical distancing, hygiene, and face mask. No? And then it became AHAL. They added Luften, which is ventilation. And I did want to emphasize that the German government now tells people you ventilate your room several times an hour. I think we have to consider that. No? It's going to become very crucial in our COVID-19 prevention. East Asians, the Chinese, Japanese, Koreans, like numbers. No? Everything should have the three, like the three goods, for example, no? Among Buddhists, no? You do good, think good, speak good. No? And it's interesting that the Japanese buzzword or the word of the year for 2020 is sanmitsu. No? There's the kanji letters, which is actually an elaboration on physical distancing. No? Rather than just saying keep 1 meter distance, no? The Japanese decided to talk about the 3 things to avoid. No? And very fortunately, the 3 things to avoid was later translated into English as the 3 C's. No? So Sanmitsu says avoid crowds, avoid closed rooms. Avoid crowds, avoid close contact and avoid close spaces. So yung close contact is the one that we usually think of as a physical distancing, but we do not think of crowds as a problem. In fact, Filipinos love crowds. When we see crowds, ay, ang saya-saya. Americans are always horrified. And of course, closed spaces. That has to be emphasized over and over again, that a closed room is very dangerous if there are many people inside, because all you need is one person to infect the others. I did want to say also that the way Sanmitsu became popularized, it was the woman governor of Tokyo. And there's a picture of a street monitor where she's reminding people about the three no's, what I just mentioned earlier. Let's address the social and cultural aspects here. When I saw the lady governor's picture there, I think she's pretty popular, and people trust her. And we Filipinos have one of the lowest trust levels in the world. Only 2% agreed in a survey a few years ago that most people can be trusted. I'm tempted to ask you, how many of you will agree with that statement? So a way out there is, what I'm finding is, of course, we will trust celebrities, but we don't trust politicians as much. And so why not do what the Japanese did, which was to use cultural icons to have certain messages? If they could use, I'm sorry, there's a missing slide here. If they could use, may nawala dito. They use a mythological creature, a mermaid that all the Japanese know, a mermaid that warns people about epidemics and wards off the epidemic. So in the Philippines, why don't we use Darna or Sasa Saturn? Here it is, the Amabi, which is also a word of the year candidate. So it's a half mermaid, and they used it for their messages on stopping COVID-19. So it sticks in people's minds. Okay, so I said, why don't we use Darna and Sasa Saturna? Sasa Saturna was a transgender parlerista who would take something na yung parang yung bato nga, and then become someone like Darna. And that will stick to people's minds. But we think that we have to be serious all the time, and we don't use it. Don't reinvent the wheel, quote the authorities, but with a bit more flair. The U.S. Centers for Disease Control has excellent advisories, but do be aware that Trump censored several of their messages. They have become unreliable for some aspects, especially about school openings. World Health Organization also has excellent information, but they're not very good with graphics. It's very text heavy. And pugay ito, Mr. Tayag, na Philippines Department of Health is doing a very good job with graphics, and learning to tap social media. But I think sometimes it's not getting out to more people. But social media, they've been very good at using Facebook. Nagugulat ako, because I have advised them on some things, and they were able to put together infographics, and nagulat ako because I had friends in Mindanao who said, ay, nakita ko yung infographic mo na So the DOH is reaching people. It's just that DOH is not able to convince people just yet, as Dr. Tayag mentioned a while ago. Let's pick your battles. We know with vitamins, even doctors will say, wala namang mawawala. But I think we should balance it out and emphasize that there's nothing proven yet about vitamins for preventing COVID-19 infections, not even vitamin D. It's not conclusive. And we have to promote the alternatives like good nutrition, exercise, fresh air, and sunlight. And I suggest, I would love to see PSMID coming out and being more ruthless in pointing out supplements are expensive and they are often ineffective. Okay, the last point here, last part, when to have your messages. Kung sa reseta may ano kayo sa dose. Dito sa COVID-19, it's how often as needed. Messages fade very quickly because the internet is so overloaded and the infodemics are virulent. So as often as needed. But you need to time it. Timing is essential. For example, a celebrity who gets infected and who is willing to speak out, nako, ang haba ng mileage dito. So strategic windows of opportunity need to be recognized. And we need to have early warning, especially for some of the scams. But it doesn't have to be scams. Recognize that in the pandemic, popular culture has been moving very rapidly. Remember, parang kahapon lang, when people were starting to use masks, but the DOH said, no, don't use masks, don't use masks. But people and finally WHO said, yes, we should use cloth masks, do not use the medical mask, but people were still doing it. No, I noticed officially, the medical establishment has not endorsed shields, but local governments have been running far ahead and requiring the shields, no, and other coverings, even without the endorsement of medical authorities. No? And I did want to give that again, going back to what we anthropologists do. No? Anong nakita namin sa kalsada? No? For example, gators on the left, no, are so popular, no? And I would love for PSMID to speak out, no? And there's a lot of research going on right now, and there are concerns that many of the gators are using materials which will not block the virus. Okay, so it's going establishing it once and for all, no, about the gators, no. But here's the very interesting cultural angle. I talk with people who use gators. They say they feel more protected kasi pati ang liig nila, no. And then I have to tell them, no, you have to use the correct types of masks. No? I hope too PSMID speaks out about masks with filters. No, warnings all over now in the States that the filters actually allow you to become a source of the infection. If you are infected, it will go through the filter, and if there are infected people around you, enters. It affects you as well, and they're very popular in the Philippines as well. And so look out into the streets, look out into the window, look out of the window. No? I was just in a 10-story building, no? Beautiful building, and I was so horrified. All the windows had these signs: "Do not open the window." No? They said it's to prevent suicides. No? They're not a hotel, but they don't. But I said you have to open the windows from time to time, no? Because you need the ventilation. They're not convinced. No? They said nasa hangin. Ayan na naman. No? I went to this condo office one time, and they asked me to wait inside an aircon room, a tiny room, and I could almost see the COVID-19 floating around. No? And then nearby was an office there were 5 people in something that looked like a 10 square meter room. No? Naawa talaga ako sa kanya, no? And kanila. And the person who was dealing with me said, di bale sir, naka-antibody testing naman sila eh. The false security. Okay, we're almost completed. Final messages for PSMID. Your turf is important. You deal with infections. Recognize too that the infections are still a gray area when it comes to public comprehension. I mean, people really still do not understand infections, what I mentioned earlier, HAWA versus resistencia. No? Learn to translate and to demystify the medical jargon. No? Reach out. No? We say symbolic capital, meaning because you are infectious disease specialists, people will listen. You are considered the experts and the specialists. No? Unlike so many instant experts out there. Okay, sorry, may hugot din. And then groom your celebrities. You have to play the game. I think Dr. Desturia was reaching celebrity level. No? But don't fall into the trap of being a celebrity. You have to speak with PSMID authority. No? Last slide. My last slide, this is an amusing one that made it to Washington Post, but it was actually shot in Quezon City, no? And I think came out in Star. No? Someone noticed that the cats were doing, ang tindera kasi nagguhit siya ng mga white circles, no? To tell people to do the physical distancing. Believe ka, you know, this again shows that Filipinos will comply if they're convinced, no? But the funny thing here is, ang nag-comply dito ang mga pusa, no? I'm a veterinarian as well, and I'm not surprised. Cats love circles and squares, no? They will sit right in the middle, no? But this was a lost opportunity. I kept telling DOH, no? Gamitin niyo ito, no? And what's the message that you can use? Kung kaya ng pusa, no? Or kung ang pusa ay nagsa-social distancing, bakit hindi ang mga tao? No? And I have tons of materials that we social scientists have been collecting. We would just love to work with PSMID. No? If you tell us you will help, we will send you the materials, no? These little pictures na kayo ang bahala to transform it into messages that the public will catch on to and for which they will be forever grateful to you. No? Maraming salamat. That ends my presentation.
Thank you, Professor Michael Tan, for sharing with us your thoughts as a social scientist on risk communication. We're going to start the open forum. And thank you, everyone. You can post your questions in the Q&A portion of this platform. Professor Mike, many times the IATF has to reverse its decision
Mm,
based on thoughts, perspectives of other groups that actually are able to convince them. For example, just the other day, they
mm,
were allowing children accompanied by parents to be brought to the malls, and they have since reversed that
mm,
because the medical societies voted against it, and even our Secretary of Health.
yes.
Just now, it was announced that the IATF has allowed the conduct of workshops, trainings, seminars, congresses, conferences, board meetings, colloquia, conclaves, symposia, and consumer trade shows in
Mm,
GCQ's areas, but only up to 30% of venue capacity.
mm,
What do you think again if other groups will try to convince IATF to reverse their instructions on this one?
mm.
Will this affect the credibility, or are they speaking to different audiences? That's why the message is very clear. Open the economy. That's why they have this
Yes.
message.
You got it there when you say there's pressure to open the economy, nga, no? And that's understandable. Um, but my question really is, nagsasalita ba kayong mga doktor? No? Maybe you'll tell me hindi nakikinig. No? I know that because DOH has said several times also na hindi kami ang magdedesisyon. And I'm always so shocked with that. No? Kung hindi ang DOH ang magdesisyon, sino pa ang ano dito? And they say it's the IATF. And it's the non-doctors apparently who are calling the shots. And I feel that's very sad. No? Naglalaro tayo sa buhay ng mga tao. No? But I think morally, the doctors, especially infectious disease specialists, will just have to keep on making the public statements. No? I would like to see PSMID speaking more often. Sometimes the IATF and other politicians, they will give in to the pressure. With them, I think kailangan ng konting panakot. No? You always have to ask them, nakahanda ba kayo kung mag-outbreak ulit? No? And we know there will be outbreaks with some of those things. The thing about the malls, it's interesting. We should be looking at Spain's exam. Spain was very strict with the lockdown, but they realized also, and I agree there, after 1 month of lockdown, they realized that the kids could not stay sequestered. So they allowed 1 hour a day, pwedeng lumabas ang mga bata kasama ng adults, but only to walk around and to bike. No? I will definitely not support allowing them to the malls. The malls are just too risky. No? I've been to the malls and people are they're breathing down your neck on the escalator. Nakakatakot talaga. No
Okay.
wonder theaters are so popular. No,
Okay.
no,
Thank you, Dr. Tan, for sharing that. No for children at the malls. Here are a couple of questions from our delegates.
Mm-mm.
One, some people like to use incentives compliance to protocol to make people toe the line. I believe this is wrong. What is your opinion on this? Will it be effective for the Filipino mindset?
Yeah. Actually, wala
And
akong naisip na, I read it na kanina, no? Have we used incentives? Kasi minsan ang reaction ko is we do not praise people enough for, kahit praise na lang, no, pugay. Kasi pinapagalitan lagi yung mga tao, pasaway kayo na ano. And when people comply, we should also praise them. Now, I don't know what those incentives were. Sana kung sino ba yung si Faith Villanueva, if you can tell me an example of incentivizing compliance, no, with the protocol. No?
thank you, Faith, for that question. Here's from Marian Quack. The PSMID has a SOCMED committee and health education committee. I think we'll be more than willing to collaborate with the social scientists to be more effective in communicating. And
Okay.
he says, thank you for a wonderful lecture.
Mm.
Congratulations.
Yes.
Uh,
I will
Bakit nga
contact you.
bawala raw risk communication czar? Ang daming czar. May vaccination czar, may contact tracing czar, may testing czar, may treatment czar. Walang risk communication,
Yeah.
risk communication czar.
Actually, we should be tapping ng the disaster resilience, malapit na daw maging department nga yan. No? They have the risk communication people there. Masscom sila. But hindi pwedeng masscom lang yan ang punto.
Okay.
Na
Here's one
you
who's
have to
seeking.
let people, hindi, ano.
Yeah,
Mm.
thank you,
Go
Professor.
ahead. Mm-mm.
Here's an anonymous, someone who's anonymous, but
Mm-mm.
he's seeking your advice on the discrimination of
Mm.
healthcare workers,
Yeah.
COVID recovered
Yeah,
patients.
it's so bad na ano. This is why I've been urging our media friends, no, including Howie Severino, who himself is a recovered patient. I said, you need to feature more of the recovered patients, no, para may human interest angle dito and our healthcare workers, no. Uh, it's as simple as that. We need to feature them more, in the media.
Okay. Aside from Darna and Zaza Zaturna, are there other figures or mythic characters that we can tap so that we can provide
Mm,
messages just like what specific countries you've
mm,
mentioned earlier,
yeah.
Professor?
That's where we might need to do quick surveys, what would work, no. Pero feeling ko si Darna especially is such an icon, no, na let's top Darna, no. And I'm sorry, I just see in the Q&A medyo
Okay.
nag-cross circuit. I see Dina Dayaw with a question, sabi ko parang Dina Dayaw and Darna, no. So can I go ahead, Dr. Tayag, na si Dina's
Yeah.
asking advice to offer people who want to organize family reunions and get together. I think even in other countries they're saying keep it small, no. No clan reunions. Mahirap lalo pang Pilipinas, ang angkan ay 50 mga tao dito, no. You cannot say kilala ko naman sila eh. I mean, really, do you know where your relatives have been, no? Yeah.
Okay. Here's a dilemma that was just posted. How
Mm-mm.
do we communicate to a governor who promotes misinformation, does not wear face masks most of the times, hates and shames doctors?
Mm-mm.
We're not going to identify this local chief
Yeah.
executive. So
Mm-mm.
it's just like in the US, there are
Yeah,
presidents
president mismo.
there. Yeah, it's
Yeah.
President
Mm-mm.
Trump, for example, that won't
Mm-mm.
wear mask and advise otherwise.
Mm-mm. That's reminding me na maybe we should I will talk with our public administration people in UP Diliman. No? I thought about it already before na sana mag-ratings sila, no, of our local government leaders, no, na and call out people like that kasi malapit ng eleksyon, di ba? It's around the corner. I think if they feel that their behavior can actually threaten their re-election, they will be more careful. No? And we really should give credit to the very effective governors and mayors, lalo pa sa mayors, no. Pasig Mayor has been so good, no. He has combined compassion and science, no. And we need to, at marami pang mga iba, no. I've been hearing and I wish we could feature them na nga, no. Mm. And try to give short
Okay.
answers. Mm.
Well, here's something that's might actually have a pinch of pain for us at the DOH, but I have to provide this to you, Professor Mike.
Mm.
I
Mm.
agree with the observation that doctors in the know tend to just observe the situation from the outside.
Mm.
An
Mm.
example is DOH allows the LGUs to make their own rules and to not follow the infectious disease experts.
Yeah.
Although I may disagree,
Mm.
Professor Tan can give his views on this.
uh, that's a problem because we had the devolution thing, no? And you know that, no, as DOH nga. And maybe there's just too much variation there. And my concern really is it confuses people eh. Yung you just cross from one town to another, iba na yung multa, iba na yung requirement. Some towns require face shields, others don't, no. And we need to be more consistent with our prescriptions, no? I'd be curious, Dr. Tayag, you said you disagreed with this question or comment. Why don't you tell
Um,
us what you think?
well, it's also possible that they do not have the guidelines. They
Oh.
don't have the capacity to implement these guidelines.
Mm-mm, mm-mm,
They were ill-advised, and
mm-mm,
this happens.
yeah.
And even in experiments,
Mm-mm,
you have a line of different people,
mm-mm,
and one has the message, and you whisper in the ear. At
mm-mm,
the end, at the other end, the last person will have a different message from the original one.
mm-mm,
So
yeah. Yeah.
yeah,
Mm-mm,
and this has been proven. And so Therefore, you have to make sure that everyone gets the message. But because we have so many messages, so it confuses everyone. So just
Yeah.
having 3 messages and not all the 20 messages that you want to bring it out there can actually help.
Information overload.
Yeah. Professor Tan, here's a question
So
because
sorry, Dr. Tayag.
everybody is, yeah,
Sorry,
last
Dr.
question.
Tayag. Dr. Tan, we need to wrap up po.
Okay.
Mm-mm.
Just last one. There
Mm-mm.
are anti-vaxxers and we are anticipating COVID-19 vaccination. How do we handle this?
Ay, nako, major challenge yan. No? And we have to recognize the Dengvaxia problem has may spill over yan. No? So let's be prepared. It will be a serious problem. I can anticipate. No?
Okay. PSMID will be working with you, Dr. Tan. We
I
need
hope
to
so. No?
expertise.
Dr.
Also the
Marion,
DOH.
oh,
And thank you everyone for participating
and
in
Dr. Alesna, please tell me who the governor is. Okay,
and
thank you as well.
okay. And please remember, okay, before you say anything, before you click anything,
Mm-mm.
think twice, think thrice, think many, many times. Thank you
Okay,
so much and
thank you
good
as
afternoon,
well.
everyone.
Mm-mm. Magandang gabi sa lahat. No?
Good evening. Okay. Please excuse the slide. I'll
John, you're good?
Yeah, I'm good. Are we on?
Yes, go ahead.
Turning my
Okay.
camera off.
All right. Good evening again to one and all. We are now on Plenary 11, and our topic for today is sepsis and COVID-19. Okay. Let me introduce our speaker for today. So our speaker is an infectious diseases consultant and public health specialist. She is the leader of the diagnostic network of Médecins Sans Frontières International, or MSF International, in Geneva, Switzerland. She's a former technical officer of the Research Ethics and Knowledge Uptake and team member of the R&D Blueprint of the WHO. She's a former senior consultant of the Department of Infectious Diseases and head of the HIV program of Tan Tock Seng Hospital in Singapore, a former diagnostics policy advisor and antimicrobial resistance advisor of Médecins Sans Frontières Access Campaign in Geneva. Friends and colleagues, please welcome Dr. Arlene Christine Chua.
Good afternoon, everybody. It's an honor to participate to the 42nd Annual Convention of the Philippine Society of Microbiology and Infectious Diseases, and congratulations on the 50th anniversary of the Society. I would like to thank the organizers for inviting me to speak today. The topic of this talk is on sepsis and COVID-19. I will present the current understanding and common features of sepsis and SARS-CoV-2 infection, as well as the evidence on treatment of severe and critically ill COVID-19 patients. My talk will focus on 2 parts. The first part will be to review the close relationship between sepsis and SARS-CoV-2 infection. And the second part will be to summarize the evidence on treatment of critically ill patients with COVID-19. So let's start with sepsis. Sepsis is a clinical syndrome with manifestations of physiologic, biologic, and biochemical abnormalities caused by a dysregulated host response to infection. The inflammatory response in sepsis can lead to multi-organ dysfunction syndrome and death. The definition of sepsis has evolved over time. The systemic inflammatory response syndrome, or SIRS, is no longer included in the definition since it is not always caused by an infection. So the latest definition is sepsis 3. It was defined in 2016 by the Society of Critical Care Medicine and the European Society of Intensive Care Medicine Task Force. They defined sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis 3 proposes also using the SOFA score. SOFA stands for Sequential or Sepsis-Related Organ Failure Assessment Score. It assesses organ dysfunction in the presence of infection. The score is composed of several variables, including respiratory, coagulation, liver function, cardiovascular function, brain, and renal function. As you know, there are many online SOFA scores that you can use on the web. What's important to note is that the SOFA score is an organ dysfunction score. It's not diagnostic of sepsis, nor does it identify those whose organ dysfunction is truly due to infection, but it rather helps clinicians identify patients who potentially have a high risk of dying from infection. So, in short, the proposed criteria of sepsis 3 using the SOFA score might be difficult to operationalize in healthcare settings. So most hospitals still use the following clinical definition of sepsis. Presence of infection with systemic manifestations, including physiological variables such as temperature, pulse rate, blood pressure, respiratory rate, and altered mental state, supported by the presence of inflammatory variables, an increase or decrease in white blood cell count, or increase in CRP or procalcitonin, presence of organ dysfunction, which could be arterial hypoxemia, acute oliguria, elevated creatinine, coagulation abnormalities, hyperbilirubemia, and tissue perfusion variables such as decreased capillary refill and increased lactate. In this figure on the model of the pathogenesis for COVID, it shows essentially two superimposed phases. First is the viral infection, where early symptoms include the host response in response to the virus. If the individual's immunity limits the viral infection, symptoms will resolve and patient recover. And as we know, in a subset of patients with COVID, there appears to have an ongoing inflammation described as an exuberant response which causes severe symptoms. This latter phase presents very similarly to sepsis. We know that they represent around 20% of patients. 80% of patients with SARS-CoV are present with mild, which means they have no or mild pneumonia. 15% will have some severe manifestations. They'll have dyspnea or hypoxia, or radiologically, they may have more than 50% lung involvement in imaging within 24 to 48 hours of presentation. And 5% are considered critical. They will have respiratory failure, shock, or multi-organ dysfunction. In terms of multi-system organ dysfunction in severe COVID cases, the following have been described and reported in the literature. So respiratory studies conducted by Wu and Wang shows that among hospitalized patients, 20 to 41% will develop ARDS. Among patients with COVID-19, underlying cardiovascular comorbidities, we know that hypertension, diabetes, and cardiovascular disease have been associated with adverse outcomes. but it has also been described that cardiovascular complications, including myocardial injury, heart failure, and arrhythmias has been associated with poor outcomes. Evidence of myocardial injury has also been described. In terms of liver dysfunction, liver function abnormalities have been described. In one study, total bilirubin elevation was reported in 10%, AST abnormalities in 21%, and ALT abnormalities in 22% of patients. In other case series, ALT abnormalities were reported in 16 to 53% of cases. No cases of acute liver failure has been reported in the literature so far. Liver dysfunction has been mainly reported in patients with severe diseases. In terms of hematological parameters, it has been observed that lymphopenia occurs and is one of the key lab findings in COVID-19 patients, which also has prognostic potential. It has also been observed that abnormalities are more prominent among severe versus non-severe cases. Hypercoagulability is also common among hospitalized patients, especially those with severe disease, like elevated D-dimer levels, prolonged PT, PTT, and severe thrombocytopenia leading to DIC. Neurological symptoms have been described from headache, anosmia to impaired consciousness, and this has been reported among mild to severe. However, it has been noted that severe cases have a higher prevalence of neurological manifestations, with reports of 84% of CNS manifestations in hospitalized patients with ARDS due to COVID. Acute kidney injury is more common in critically ill patients, with some patients requiring renal replacement therapy. What about the immunology of sepsis and COVID? So as infectious disease doctors, we are aware of the normal host response to infection. This process is highly regulated by a mixture of pro-inflammatory and anti-inflammatory mediators. Sepsis occurs when the release of pro-inflammatory mediators in response to an infection exceeds the normal response and leads to a more generalized response, leading to uncontrolled and unregulated response or an exaggeration of the normal inflammatory response. Some of our understanding on the pathophysiology of sepsis includes the involvement of innate immunity and inflammatory mediators. There's release of pro-inflammatory cytokines. These cause activation and proliferation of leukocytes, activation of complement system, upregulation of endothelial adhesion molecules and chemokine expression, tissue factor production, and induction of hepatic acute phase reactants. In sepsis, there is an exaggeration of the above immune response resulting to damage of cells and tissues. Dysregulation of hemostasis, there is an intersection between the inflammatory and coagulation pathway in sepsis. The etiology is multifactorial. The hypercoagulability of sepsis is thought to be from the release of tissue factor from disrupted endothelial cells. Tissue factor causes systemic activation of the coagulation cascade, resulting in the production of thrombin, activation of platelets. In addition to these procoagulant effects, there is also the depression of anticoagulant effects due to protein C and antithrombin. In terms of immunosuppression, there is also an eventual decrease in the number of T cells and a decreased response to inflammatory cytokines. Cellular, tissue, and organ dysfunction is due to the decreased delivery to and utilization of oxygen by cells as a result of hyperperfusion. As you can see in this slide, biomarker abnormalities in severe COVID-19 patients are very similar to what is observed in our understanding on the pathophysiology of sepsis, as I just described in the previous slide. How about bacterial co-infection? Does it contribute to the sepsis picture in COVID-19 patients? We currently have limited data, but bacterial superinfection does not appear to be a prominent feature of COVID-19. I present here 3 studies that have been published in the literature looking at the degree to which bacterial co-infection exists in COVID-19 patients. In one retrospective cohort study of 354 hospitalized patients with confirmed COVID-19 in China, 116 patients were tested for co-infection based on clinical suspicion. 3 positive results for viral co-infection from 76 patients tested by sputum PCR, and 20 positive results for bacterial or fungal co-infections from 40 patients tested by culture or BAL fluids. There was no distinction made between community-acquired and hospital-acquired infections. The most prevalent pathogens is A. baumannii, E. coli, and Candida albicans. Co-infection was associated with worse COVID-19 severity. In another study, retrospective study cohort in the UK, SARS-CoV-2 group had 3.3% bacteremia. In another study looking at Spanish COVID-19 cohort, they found a 3.1% community-acquired co-infection rate, which was lower than co-infection in past influenza pandemics and not associated with higher mortality. They also found a 4.3% hospital-acquired superinfection rate, which was associated with longer hospital stays, more ICU admissions, and higher mortality rate. So based on the evidence we have until now, overall, bacterial or fungal co-infection as a cause of sepsis in COVID-19 patients seems to be relatively low, supporting the suggestion and discussion in the scientific community that SARS-CoV-2 could be the main cause and driver of sepsis in COVID-19. So in summary, for the first part of my presentation, severe cases of COVID-19 show similarities with sepsis syndrome in terms of the physiologic, biologic, and biochemical inflammatory abnormalities resulting in multi-organ dysfunction. Bacterial co-infection in COVID-19 does not appear to be enough to account for the sepsis picture in COVID-19. The next part of the talk, I will present the evidence on treatment of severe COVID-19. Just to note that I will not mention the non-therapeutic management of COVID-19. As mentioned earlier, a way of understanding COVID-19 treatment is to consider several phases of the infection, where the first phase is the viral phase and the second phase is the inflammatory phase. The key therapeutic classes under investigation for treatment of COVID-19 can also be divided into 2 categories: antivirals and immunomodulators. The treatment modality and goals will be different. The first phase treatment goal would be to have an antiviral effect, which would include antivirals as well as the use of convalescent plasma or monoclonal antibodies. And the second phase treatment goal would be to modulate the immune dysregulation with the use of steroids or use of specific or targeted immune response, such as interleukin inhibitors. I will focus on the evidence of treatment in severe COVID-19 cases, the stage that I've highlighted here in a red box. There have been several studies on the use of systemic corticosteroids in severe and critically ill COVID-19 patients. I read here the names of these randomized clinical trials. For dexamethasone, you have the DEXA COVID-19 study, CODEX, Recovery. For hydrocortisone, you have CAPE COVID, COVID steroid, REMAP COVID, and for methylprednisolone, you have steroid SARI. A meta-analysis of systemic corticosteroids in critically ill patients with COVID-19 has been conducted by the WHO Rapid Evidence Appraisal for COVID, or the REACT working group, and this was published in JAMA. It's a prospective meta-analysis that pulled data from the 7 randomized clinical trials that I have shown you in the previous slide. It evaluated the efficacy of corticosteroids in 1,703 critically ill patients. The primary analysis was on overall mortality at 28 days, and the secondary outcome was investigator-defined serious adverse events. Patients were randomized to receive dexamethasone, hydrocortisone, or methylprednisolone versus 1,025 patients who received usual care or placebo. The results were 222 deaths among the 678 patients randomized to corticosteroids and 425 deaths among the 1,025 patients randomized to usual care or placebo. The odds ratio of deaths was 0.66 with a 95% confidence interval of 0.53 to 0.82 and a p-value of less than 0.001. The fixed effect summary odds ratio for the association with mortality was 0.64 for dexamethasone, 0.69 for hydrocortisone, and 0.91 for methylprednisolone. So overall, it shows that the administration of systemic corticosteroid was associated with the lower 28-day all-cause mortality versus placebo. Corticosteroids were also associated with lower mortality among the severe patients who were and were not receiving invasive mechanical ventilation, and also among the patients in the recovery trial who required oxygen. In terms of adverse events of those patients who received corticosteroids, there was no suggestion of an increase in adverse events. Among the 6 trials that reported serious adverse events, 64 events occurred among the 354 patients randomized to corticosteroids and 80 events in 342 randomized to usual care. This is the current recommendation of WHO on the use of corticosteroids. So they recommend the use of systemic corticosteroids in patients who have critical COVID-19 as well as severe COVID-19. And they suggest not to use systemic corticosteroids in patients who have non-severe COVID-19. Just to read out here again the definition, and I know this has probably been defined in the various sessions in the conference, but severe COVID, it's defined by any of the following: a patient having an oxygen saturation of less than 90% on room air. Although this should be interpreted cautiously, and clinicians must use their judgment to determine low oxygen saturation as a sign of severity. So in some situation, it could be between 90 to 94%. This may be considered abnormal depending on the patient that you're seeing. Severe COVID is also defined in patients with a respiratory rate in more than 30 breaths per minute in adults and children more than 5 years old. If also patients have signs of severe respiratory distress. Critical COVID is defined as patients having acute respiratory distress syndrome, or ARDS, who also meet the definition of sepsis or septic shock, or other conditions that would normally require the provision of life-sustaining therapy, such as mechanical ventilation or vasopressor therapy. In terms of what is the recommendation on how to use systemic corticosteroids? They can be given either orally or intravenously. The medication type, it could be dexamethasone or other corticosteroids such as hydrocortisone or prednisone. In terms of the dose, once daily regimen of dexamethasone, 6 milligram once daily, or an equivalent of 160 milligrams for hydrocortisone, or 40 milligrams of prednisolone, or 32 milligram of methylprednisolone. The duration is recommended to be between 7 to 10 days. Obviously, to monitor glucose level when somebody is put on steroids, and to monitor also the adverse effects. In terms of cost and access, we know that this corticosteroid therapy, this is a low-cost intervention. It's easy to administer, and it's available globally. Similar recommendations on the use of corticosteroids have been given by the Infectious Disease Society of America and the National Institute of Health. Another immunomodulator that has been investigated is interleukin-6. Why interleukin-6? Interleukin-6 receptor inhibiting monoclonal antibody. It inhibits the interleukin-6, which is a known pro-inflammatory cytokine. The rationale for it being investigated is the thinking that the cytokine release syndrome in the second phase of COVID-19 in severe patients, this accounts for the clinical severity, or ARDS or sepsis in these patients. This interleukin-6 receptor inhibitor monoclonal antibody is called tocilizumab. So here the study was published in the New England Journal of Medicine. It's a randomized double-blind placebo-controlled trial involving patients with severe ARDS with COVID. Patients were randomly assigned in a 2-to-1 ratio to receive standard care with a single dose of either tocilizumab or placebo. And the primary outcome that they had investigated was intubation or death, and assessed in a time to event analysis. The results showed that tocilizumab was not effective for preventing intubation or death in moderately ill hospitalized patients with COVID-19. This is another immunomodulating drug. It's an interleukin-1 inhibitor called anakinra. It's a recombinant human interleukin-1 receptor antagonist. Endogenous interleukin-1 is elevated in patients with COVID-19 and other conditions, such as severe T-cell mediated immune disease. Case reports and case series have described favorable responses to anakinra in patients with these syndromes. However, there is no clinically controlled data. So it would be interesting to see if future clinically controlled trials show these more specific anti-inflammatory agents can work against COVID-19. So in summary, remarkable progress has been made in understanding COVID-19, severe disease, and its similarity with sepsis. There is supporting evidence on the use of dexamethasone in severe and critical COVID-19 patients. There is general agreement in the scientific community on its use. It will be interesting to see in future clinical studies of other specific inhibitors of immune response in the inflammatory phase of severe COVID-19 and whether they can be effective. So as we near the 1-year mark of COVID-19, let's continue to work hard, whether we are frontline workers or public health experts or academics. Let's keep the faith. Let's be critical and follow the science to inform our practice. Thank you for your attention and maraming salamat.
Thank you so much. Thank you very much for that excellent presentation, Dr. Chua. We already have a couple of questions in the Q&A box. First question, are there widely accepted, standardized, validated criteria that can identify SARS-CoV-2 positive patients who would become severe and go into hyperinflammation?
I think that there is no like universal criteria that's been published by organizations. But in the literature, investigators have looked at the difference between patients who have severe COVID, and what they've done is that they've developed a kind of scoring system so that it could inform practitioners in that particular setting to identify early who could receive more intensive monitoring or be put in the intensive care unit faster. So some of these scoring systems, for example, would consist of patients with higher CRP, procalcitonin. So we know that they do increase in severe patients. They look maybe at the degree of lymphopenia. Some of the scoring systems also look at the neutrophil lymphocyte ratio, plus other clinical parameters. So I think this might be helpful. So and this could be validated in your particular setting and patient group.
Now, there are some quarters who are skeptical about the presence of cytokine storm in COVID-19. May I know your opinion on this?
Yeah, I mean, I think cytokine storm, actually, there is still some debate, and I think in general the scientific community don't agree on. There's no common definition of a cytokine storm. Yeah. I focus more on the sepsis-like picture of COVID. And indeed, sepsis, if you just put it simply, it's essentially the presence of infection and presence of multi-organ damage, right? And then now whether the cytokines that are elevated in severe COVID and how that compares with other, infectious diseases when they do present with sepsis-like picture, we actually don't know that, because for even in the dexamethasone studies that I presented, I think there was no real look into which kind of cytokines were elevated. So we still lack that kind of studies.
Yeah, in relation to that, the next question is actually more of the cellular level. No? Have you encountered highly excited neutrophils that discharge their chromatin content when they encounter a virus? In severe influenza patients and patients with severe sepsis, these neutrophils are identified in these other subsets in great numbers, and these neutrophil subsets are seen in diabetics. Do you think SARS-CoV-2 triggers this sepsis-like symptoms? And there's a comment that colchicine has been shown in vitro to inhibit the chromatin discharge.
I mean, I think that's an interesting question. I'm afraid I haven't read anything on this. There might be some, so it doesn't mean that the literature on that is not out there. So I'm sorry, I can't. I haven't read anything on this. Sorry about that.
So this next question is on inflammation as well. No? At the start of the pandemic, there were some articles that said that anti-inflams would not be good, no? But how about the role of NSAIDs in the early phase of COVID?
Yeah, I mean, I think there were some early on in the outbreak. I think it was the French who have noticed that the patients who had received NSAIDs had a worse outcome. So there was this kind of advisory, but I think they were mostly anecdotal. And since then, it didn't really say that NSAIDs would be bad or would be even good for patients who have been diagnosed with COVID. So I haven't seen any study that suggesting or recommending that NSAIDs could be beneficial in patients with COVID.
So I think we have time for just two more questions. There's this question: how long can we give steroids if a patient is not improving in 10 days of DEXA? Because sometimes there are some quarters, it's controversial, but steroids can also be given, may be given in ARDS. So if how do you feel about extending dexamethasone in those who are not improving?
Yeah, the recommendation is 7 to 10 days. And I think beyond 10 days, I think it's the clinician judgment weighing the risk-benefit of prolonging the dexamethasone treatment if there is no improvement. I think also at that point, as a clinician, you look for other reasons of non-improvement. Maybe at that point there is concomitant hospital-acquired pneumonia or other things that may account for deterioration or non-improvement.
Thank you. Maybe one last question. There's a special comment here. Is interleukin-6 the most important cytokine causing CSS? And if so, why do you think the trials on tocilizumab do not show the benefit to date?
No, we actually don't know which of the interleukin are the kind of the main culprit in the hyperinflammatory states. I think, but some of these interleukins some of these mediators, it's not only interleukin-6, but it's also interleukin-1. There's JAK, and there's some trials looking at individually at these mediators. So not necessarily interleukin-6. I think it would be important to see what would be the results of these ongoing trials. But I think if you look at the inflammatory cascade as presented by Prof. Leo on day 1, it's not just one, it's several of these mediators. I mean, which begs the question also, is the strategy to look individually at these biomarkers with as just like one sole agent to address the inflammatory state? Does that make sense, right? Because, like, for example, dexamethasone, it's a general anti-inflammatory, right? And it does show that it does have some benefit. So we'll see. But right now, there is no indication to say interleukin-6 is the main driver of hyperinflammation.
Okay, all right. I think that's all the time that we have. But we are really, really grateful that you said yes to come and talk and participate in our PSMID convention, Dr. Chua. Thank you so much again. So let me close this session now to make way for the next session. and good evening to one and all. Thank you.
Hello.
Go ahead, Dr. Coronel.
Hello. Doktora Coronel
Go,
ito.
go
Yes,
ahead,
ma'am. We can
ma'am.
hear you.
Okay. Good evening. We are now on our plenary session 12. And we are very fortunate that we have somebody who is a young infectious disease specialist coming all the way from Alberta, Canada. He is an assistant professor at the Division of Infectious Diseases in the Department of Medicine at Alberta University. He obtained a doctorate degree in Medical Sciences, Faculty of Medicine, Medical Sciences at University of Antwerp, Belgium. He is a consultant as in a general and transplant infectious diseases, University of Alberta Hospital. He was a visiting scholar at the University of San Antonio, Texas for 3 years just for mycology. Our speaker has numerous peer-reviewed publications on COVID-19 and mycology. And without much ado, I want to present to you our speaker on fungal infections in COVID-19, Dr. Ilan Schwartz of the University of Alberta. Dr. Schwartz.
Thank you very much. And I would just like to thank the organizers for the generous invitation for me to present here. It's really quite an honor. So these are my disclosures. So I'm going to be talking today about two of the main fungal infections that we would worry about in COVID-19. The first being invasive candidiasis, and the second being COVID-19 associated pulmonary aspergillosis, also called CAPA. I'm going to briefly discuss the scarce literature on antifungal prescribing in COVID-19 as well. So there's a number of reasons why we would think that fungal infections are an important problem in COVID-19. So firstly, we know that viral respiratory tract infections can cause epithelial damage in the airways, and this can predispose to invasion of colonizing organisms. We know that COVID-19 is a disease characterized by immune dysregulation, and many of these immune processes are involved in innate host defense against fungal disease. For example, lymphopenia is a characteristic of severe COVID-19. These patients are often critically ill, and consequently we do many things to them that increase their risk of invasive fungal disease, including mechanical ventilation, central venous catheter insertion, and the administration often of broad spectrum antimicrobials. In addition to that, their immune systems are further perturbed by the administration of immunomodulatory therapies, most commonly corticosteroids, in addition to IL-6 inhibitors at some centers. Now, in general, the risk factors for invasive candidiasis overlap with those for COVID-19, including prolonged stays in the ICU, the use of central venous catheters, prolonged antibiotics, particularly of broad spectrum, and renal failure, which we know is a complication in many cases of COVID-19. In addition, many of the comorbidities that are risk factors themselves for severe COVID-19 also predispose to invasive candidiasis. There have been a number of studies that have described the prevalence of invasive candidiasis among inpatients. A small study from China described the prevalence of 4%, but a considerably larger study from Barcelona suggested that the rates may be lower than that, even less than 1%. However, there is a clearly substantial geographic and center variation, as Antonori and colleagues from Italy described up to 7% in their small series. In ICU patients, the rates of invasive candidiasis are higher. In India, Chowdhury and colleagues described 2.5% prevalence of candidemia. Now, the majority of these cases were Candida auris, a multi-drug resistant organism that plagues that subcontinent. And in Italy and Wales, the rate was between 10 and 13%. Now, we don't think there's any specific immunologic mechanism that places patients at higher risk for candidiasis. Likely, the increased rates are a consequence of these intensive medical interventions that we do to these patients. And the management should be the same as for any other patient with invasive candidiasis, the mainstay being removal of the line or other source, and administration of antifungals, namely echinocandins where available, or fluconazole. Now, aspergillosis in general is a disease of immune-compromised hosts, specifically invasive pulmonary aspergillosis, and a risk stratification of various strata of immune-compromised patients is shown here. You can see patients at highest risk are those with hematologic malignancies like acute myelogenous leukemia and myelodysplastic syndrome receiving induction chemotherapy, in addition to allogeneic stem cell transplant and lung transplantation. There are a number of other immune compromising conditions that place patients at other risks that are either high, intermediate, or low, as shown here. Now, in addition to these, in recent years, there's been increasing focus on another risk factor for invasive pulmonary aspergillosis, even outside of immune-compromised hosts. And this is as a sequelae of severe viral respiratory infections. Influenza-associated pulmonary aspergillosis has been described in the literature for decades, but it's really been increasing in frequency for about a decade, ever since H1N1 in 2009. Some seminal studies in Europe have suggested that among ICU patients with influenza, rates of invasive pulmonary aspergillosis are between 20 and 30%. We looked at the data in Alberta and found that the rates were considerably lower, around 7%, suggesting that there is significant geographic variation here. Now, not all cases were of similar severity, and the most dramatic one I'll present here. This is a 61-year-old woman with COPD. She presented with a several-day history of fever and cough in the context of some sick exposures. This is the X-ray upon presentation to the emergency department. And over the course of a number of hours, she deteriorated and developed acute respiratory distress syndrome. She was transferred to our center for extracorporeal membrane oxygenation, and she had a bronchoscopy which showed these cobblestoning mucosal plaques throughout the airway. Now, bronchial samples were collected, and these grew Aspergillus fumigatus. She was started on therapy with voriconazole and an echinocandin, but unfortunately developed massive thromboses in a number of organ systems, including massive stroke. And unfortunately, she passed away. Now, on autopsy, these acutely branching hyphae were seen throughout the body, including in the airway, the lungs, stomach, kidney, heart, and brain. Now, the experience in recent years with influenza-associated pulmonary aspergillosis has primed mycologists to look for invasive pulmonary aspergillosis in patients with COVID-19. And these are a number of the early publications that raised the alarm about this potential complication. This is a patient that we cared for very recently in Alberta, a 67-year-old gentleman with a history of COPD who was hospitalized with COVID-19. This CT scan is from soon after admission, and you can see the ground glass opacities and multifocal consolidations that are characteristic of severe COVID-19. On day 9 of admission, a sputum culture grew 1+ Aspergillus fumigatus. Now, this was not initially treated, and 3 weeks into hospitalization, he developed worsening hypoxia requiring 70% oxygen by high flow. He declined intubation, and consequently bronchial samples were not possible, but a serum sample was sent off for galactomannan, and this was positive with a optical density index of 1.5, and a positive from serum is usually 0.5. He was he had another culture that was sent off from sputum around this time, which again grew 1+ Aspergillus fumigatus. He was started on voriconazole, and a CT scan was repeated, which showed increase in the consolidations in addition to widespread cavitation. And unfortunately, he died despite antifungal therapy. So there are a number of challenges in diagnosing COVID-associated pulmonary aspergillosis, or CAPA. As I mentioned, classic host factors are usually absent, and this may impede the ability to suspect the diagnosis in patients without these classic features. Now, the radiographic findings are nonspecific and in many cases indistinguishable from those of severe COVID-19, particularly in early fungal disease. Now, many patients with COVID-19, even in the absence of superinfection, deteriorate. We know this is a biphasic disease, and so it can be difficult to discern which of these patients with deterioration may be due to complications such as secondary infection. Bronchoscopy is often discouraged in COVID-19 because it is an aerosol generating procedure. When it is done, biopsies are rarely procured because of the tenuous nature of these patients and because bleeding can worsen their clinical status. On the other hand, mycological tests of other respiratory samples are either nonspecific, such as the instance of culture on endotracheal aspirates or on sputum, or they're unvalidated, such as galactomannan on these samples. Now, there's additional challenges in studying the literature of COVID-associated pulmonary aspergillosis to get a better idea of what's going on. So for one thing, because of the rapid emerging nature of this disease, a number of different diagnostic algorithms have been proposed and have been used across different studies. Now, all of these have a proven category, which is more or less uniform, and this is a tissue-proven infection, either through biopsy or postmortem examination. And they all have a category of either probable or sometimes described as putative COVID-associated pulmonary aspergillosis. Now, these are defined by a combination of non-specific clinical, radiographic, and mycological tests or features. So clinical features include things like hypoxia or fever despite antibiotics, findings that are, of course, very common in COVID-19 itself, even in the absence of superinfection. Radiographic, the findings to fulfill the criteria are very non-specific, such as infiltrates, which of course we would expect on any patient with severe COVID-19. And as I mentioned, the mycological tests are non-specific and are unable to distinguish between colonization and invasive disease. Different studies have used different screening practices. Some have performed bronchoscopy on all patients in the ICU. Others have sampled by convenience. And as with influenza-associated pulmonary aspergillosis, we anticipate that there's geographic variation, which makes it a little bit challenging to compare between sites. Nonetheless, we did a systematic review of the literature. We looked at cohort studies of ICU patients who were screened for kappa. We reviewed prevalence rates, and we also extracted patient-level data so that we could reclassify according to the 4 of the main published definitions. These were the ASP-ICU definition, which was described almost a decade ago to try to get around the problem of the absence of host factors that were often encountered in this setting. The influenza-associated pulmonary aspergillosis consensus definition, which was published in early 2020, and which included adaptation for COVID-19. A recent definition described by Lewis White in Wales, and the European Confederation of Medical Mycology and International Society of Human and Animal Mycoses consensus definition, which is currently in press. So these are the prevalence findings from this review. Now, the size of the bar is indicative of the number of samples or the number of patients who were ventilated that were screened for kappa. And the blue indicates the number in whom kappa was diagnosed. Now, in the red line, this is the proportion of patients with kappa corresponding to the axis on the right. Now, you can see that some studies were as small as 20 people, in some cases even less, and some were as big as over 120 patients. And the prevalence rates ranged between about 3.5% in some studies to 35%. So to summarize this data, the median prevalence across these studies was 21%, with an interquartile range of 15 to 27%. If we pool all of the patients together, we get a prevalence rate of about 15%. Again, this is a questionable analysis because of the fact that these studies are quite heterogeneous, but just to give you kind of a crude appreciation for how common it is suggested based on these studies that COVID-associated pulmonary aspergillosis is. So here we compared the different definitions using patient-level data. So for each cluster of bars, these each represent a study, and each color represents a different definition. So if there's agreement across the definitions, we would expect the bars to be of uniform height. which you can see they are not. So overall, the correlation between these definitions ranged between 27% to about 65%. So if COVID-associated pulmonary aspergillosis does indeed complicate up to a third of COVID-19 patients in the ICU, the presumption or the implication being that we're missing many, if not most of these infections, then we would expect that these would be a frequent finding in autopsies, particularly if they do truly represent invasive disease. So we did another systematic review of autopsy studies. We included case series. Sorry, I don't want to trip off my artificial intelligent companion here, of at least 3 decedents in these autopsies. The lungs had to be described at minimum, and where specific information about secondary infections wasn't included, we contacted the authors for further information. We identified 51 studies that described 702 autopsies. So early in the pandemic, autopsies were infrequently performed because of concerns about occupational exposure, but this has increased over time. You can see that a plurality of these, about a third of these, came from the United States, followed by Italy and then Germany, followed by a smattering around the world. So there was enough information for a patient-level analysis for 430 of these autopsies. And this just gives you a snapshot of the patients in whom autopsies were performed in this systematic review. So the median age was 72. Comorbidities, of course, were common. A third of patients had diabetes, a fifth had chronic lung disease. Immune compromising conditions were encountered in 6% using stringent research definitions. Immunomodulatory therapy was reported to have been administered in 60 patients. The duration of hospitalization was a median of 10 days prior to death. And among individuals for whom this could be ascertained, about half had been ventilated for a median of 9 days. 10% were reported to have received antifungals. So again, among 51 studies that described 702 autopsies, what we found is that the number with invasive mold disease was only 11 autopsies, or 1.7%. If we limit our analysis to decedents that were confirmed to be ventilated, then the proportion is a little bit higher, 5 in 173, or about 3%. So among the 11 with invasive mold disease, in 4 instances, there was no attempt at speciation. In 4 instances, there was aspergillosis that involved the lungs only. In 1 instance, it involved the airways only, and in 1 instance, it involved both the airways and the lungs. And there was 1 case of disseminated mucormycosis that involved lungs, lymph nodes, brain, and kidney. And a histology of that is shown on this slide. So we compared decedents with and without autopsy-proven invasive mold disease. Now the analysis, of course, is not very robust because the number of events is so low in invasive mold disease, and so we just did a purely descriptive analysis. Now, among patients with invasive mold disease in whom ventilation status could be ascertained, just over half had been ventilated, suggesting that the risk of invasive mold disease is not exclusive to those that had received invasive mechanical ventilation. Now, at least some autopsies were done in patients who had been diagnosed antemortally with probable COVID-associated pulmonary aspergillosis, including 6 patients from this study in the Netherlands. So all of these patients had received bronchoscopies. All of them had BAL galactomannan above the cutoff, which is 1. In most cases, considerably higher than that cutoff. In 2 instances, Aspergillus fumigatus was also cultured from the airways. And in none of these cases was invasive fungal disease confirmed on autopsy. So in summary, autopsy-proven invasive mold disease appears to be relatively uncommon, somewhere between 1.5% and 3%, which suggests that many of these cases reported of probable or putative COVID-associated pulmonary aspergillosis may not represent true invasive disease. There are expert consensus guidelines for the therapy of COVID-associated pulmonary aspergillosis, and they're currently in press. The experts recommend that management essentially be the same as for immune-compromised hosts with invasive pulmonary aspergillosis. So that being 6 to 12 weeks of voriconazole or isavuconazole as an alternative where this is available. In cases of azole resistance, amphotericin B should be used. So my caveat, based on the data that I've presented here, is that many of these patients do not have true tissue invasive disease and may not require a full 6 to 12 weeks of therapy. I think that it's reasonable in patients that have clinical deterioration and mycological evidence of possible pulmonary aspergillosis to be initiated on therapy, but clinicians shouldn't feel obliged to be trapped into 6 to 12 weeks. I think it's reasonable to start therapy, and once the patient gets out of the ICU, if they get out of the ICU, then it can be reassessed. So there are many outstanding questions in COVID-associated pulmonary aspergillosis. So what are the risk factors, not just of probable or putative kappa, but of proven invasive kappa? Who should be screened and how? And who should be treated and how? Of course, this is the most relevant question. And then finally, is there a role for prophylaxis? And this is going to be investigated with a randomized controlled trial in California. There is some data that has described antifungal prescribing practices in COVID-19, which is just summarized on this slide. As you can see, it's very sparse. An initial study from China described that 15% of admitted patients had received antifungals. A larger study from China suggested that the rate was about 1/5 of that. And a recent study from the United States suggested that in units that had high rates of COVID-19 patients, there was no increase in the consumption of antifungals in the spring of 2020 compared to 2019. So in summary, invasive fungal infections are expected wherever we have critically ill patients. The risk is probably commensurate with the intensity of the medical management that we perform, including central venous catheters, invasive mechanical ventilation, the use of immunomodulatory therapies such as corticosteroids or IL-6 inhibitors. The current definitions of COVID-associated pulmonary aspergillosis are inadequate to guide individual patient management decisions. And the prevalence of autopsy-proven invasive mold disease is considerably lower than antemortem diagnoses. I'd like to thank 2 talented trainees who worked with me on these projects, Dr. Brittany Kula, who's an infectious disease fellow, in Alberta, and Dr. Ruwandi Kariwasam, who is a clinical microbiology fellow. And as always, I close by thanking my family, without whom none of this work would be possible. Thank you very much for your attention, and again for the invitation. And I'm happy to take any questions.
Okay, thank you, Dr. Schwartz, for that very informative discussion on COVID-associated pulmonary aspergillosis and fungal infections in general. We have several questions in the Q&A box. I'll start off. Good day, Dr. Schwartz. Are these fungal infections not from the effects of prolonged treatment on COVID-19 patients, such as steroids and interleukin inhibitors?
And so we know that corticosteroids are a independent risk factor for COVID-associated pulmonary aspergillosis. Now, the doses that were used in the recovery trial of 6 milligrams of dexamethasone a day theoretically should be a lower risk than higher doses typically used in sepsis. But we haven't, we don't have a lot of good data, again, with correlation to the gold standard, which is proven invasive disease. Similarly, we don't have a lot of data to inform the risk of invasive fungal disease with tocilizumab or other IL-6 inhibitors, although we assume that it does increase the risk, and anecdotally this seems to be the case, but this hasn't been proven.
Okay, thank you. And then another question, when will you suspect kappa? Is there a telltale sign or symptom that we should look out for?
So this is one of the many problems, is that patients with severe COVID-19 clinically deteriorate. This is the natural history of the disease, and so this makes it more difficult to distinguish superinfection. Whereas in, for example, influenza, if a patient it has severe disease and then secondarily deteriorates, then you might look for primarily a bacterial superinfection, but you might also consider a fungal superinfection. Now, in COVID-19, we know that that's par for the course. So it's a little bit more challenging. There's no telltale sign, and it's very challenging, again, because of incomplete specificity of diagnostics. So what I recommend is that if patients clinically deteriorate, if they have a consistent clinical picture and mycologic findings that support the diagnosis, if clinicians are worried about that patient, then I think it is reasonable to initiate therapy. But again, I think that it is also wise to have an exit strategy rather than committing the patient to 6 to 12 weeks of antifungals, because the majority of these patients won't have true invasive disease. However, I think it's reasonable to defer that decision until a little bit further down the road when they're clinically a little bit better.
Okay, you mentioned that. I'll do a follow-up question regarding the challenge for diagnosing with bronchoscopy. So in most of the patients, especially the vulnerable population, how early should bronchoscopy be, and as an infectious disease physician, do you actually insist on it, knowing that it's an aerosol generating procedure, but you also need a diagnostic test?
Yeah, so we're not really in a position to insist per se. We can advocate for it, and in my experience, there's different willingness in different centers to do bronchoscopy. Even outside of COVID-19, different centers have different rates of bronchoscopy, and so it's very much depends on not just the center, but the individual operator, whether they are comfortable with that procedure in this setting. I don't have a good guideline on when to insist on this procedure, but I think that it is important in patients that deteriorate, particularly if it's a little bit beyond what you would expect with the natural history of disease. And I know that's a vague description, but unfortunately I can't be much more specific than that. This is particularly an issue for tracheobronchial disease, which is more common in influenza, because these patients may not have radiographic findings, certainly not the classic radiographic findings that we associate with invasive pulmonary aspergillosis, things like nodules or halo signs, cavitation, things like that. And so the diagnosis of tracheobronchitis can only be made with a bronchoscopy. I think this is a little bit less common in COVID-19 associated pulmonary aspergillosis than influenza. But I think that bronchoscopy does still have an important role. I think this is particularly important in patients where there's some initial mycological evidence. So for example, if you do have an endotracheal aspirate that's growing aspergillus, then I would push for a bronchoscopy, because it's, again, very difficult to distinguish upper airway contamination or colonization from representing true lower respiratory tract disease.
Okay. Other question would include, but besides systemic mycosis, do you see also an increase in dermatomycosis, subcutaneous mycosis in these patients?
So this is likely to be a regional thing. So, inoculation mycoses are predominantly diseases that are seen commonly in the tropics. And so we don't see as much of these outside of, the occasional case of sporotrichosis. I don't see a reason why this would be more common, although, as I mentioned, there are some, very non-specific immune dysregulatory factors that may increase risk of infections in general, including in fungal infections. But I haven't seen any specific case reports or any data about dermatomycoses. There have been a few reports of endemic mycoses, such as histoplasmosis, but it does seem to be fairly uncommon, and it's probably more related to other underlying risk factors, such as advanced HIV.
Okay. How do you feel about the use of upper respiratory samples, tracheal aspirates, to aid mycological diagnosis?
So I think there's a role for it in piquing suspicion, but these tests are, as I mentioned, non-specific, and so it's difficult to know whether to act on these results alone. I think that these findings would certainly give an ID physician more standing in advocating for lower sampling through bronchoscopy, but often these may not be available, and so you have to just make a decision based on those upper respiratory tract samples. I think in the right clinical setting, if clinicians are concerned, again, I think it's reasonable to err on the side of initiating therapy and then reassessing a week later.
Okay, and so if we have the respiratory sample, when will we suspect the growth of Aspergillus in sputum being a colonizer as opposed to that of a real infection?
When we suspect the growth?
Yes.
Colonizer. Yeah, so I'm not entirely sure on the question. So we don't have any useful markers of whether it's a good sample that represents a lower respiratory tract specimen, such as in bacterial gram stains, for example. I think particularly in patients that have structural lung disease like bronchiectasis, it's certainly not uncommon to have aspergillus in sputum or aspergillus in an endotracheal aspirate. So in these patients, I would have a little bit more skepticism, but with that said, I think they are at slightly higher risk as well. So unfortunately, this is an unsatisfying answer, but we don't know, and that's why these definitions and these criteria are so vague, because they want to ensure that these cases are captured and not dismissed, but at the same time they lack specificity. And so I think they're going to push clinicians on the side to err on the side of overtreatment rather than undertreatment, which of course introduces another set of problems. We know that antifungal stewardship is a very nascent area of stewardship, so we don't want to throw it by the wayside. But again, I think given the high potential mortality with this disease, I think it's reasonable to be conservative with initiating initial therapy.
Okay, and for this last question, would there be any probable association between tuberculosis, especially those with anatomic abnormalities already, with COVID and Kappa, since the Philippines is a high burden country for TB?
Yeah, that's an excellent question. I don't know. I mean, we know that chronic pulmonary aspergillosis commonly complicates old TB. And so, these types of structural lung abnormalities, similar to structural airway abnormalities like bronchiectasis, make it more likely that patients are colonized with the organism. And that's, of course, the first step to invasive infection, but I don't think that it's a natural extension. So I don't think that everybody who has old TB is likely to have COVID-associated pulmonary aspergillosis, but I would have a higher index of suspicion in these patients.
There are two follow-up questions. Where are we in terms of antifungal resistance?
So there's a lot of regional variation to this. To be honest, I don't know what the data is in the Philippines. In some countries in Europe, particularly the Netherlands, where they basically water their tulips with azoles, there's high rates of resistance, upwards of 10% in clinical samples. In Canada, it's exceptionally rare, and other countries where the farming practices aren't as intensive with crop farming. I suspect, just based on what I know about other countries in Asia, I suspect that azole resistance is on the rise, but is still relatively uncommon. If the isolate is not Aspergillus fumigatus, then I think that, particularly if it's Aspergillus terreus, then resistance is more likely. And so in these patients, certainly I think initial therapy with amphotericin B would be appropriate.
Okay, and do you recommend antifungal or Kappa prophylaxis in high-risk COVID-19 patients with ARDS?
So I do not. I don't think we have enough data to support this. Again, truly invasive mold disease is relatively uncommon in this population. We know that azole therapy or prophylaxis carries risks of drug-drug interactions, of liver injury, and so these are not benign drugs. So I think that I would caution against prophylaxis.
I have two more questions from the panelists, actually, and we still have time. So, is there evidence to show that tocilizumab increases fungal infections, and do you use tocilizumab in your practice?
So the evidence is anecdotal. I would say that it's a fairly good assumption. It makes biological and physiological sense that it increases risks, but the link has not been clearly established, and the randomized controlled trials that have been reported so far have not actually reported higher rates of secondary infections, either bacterial infections or fungal infections. This has been observed in some observational studies, but it's been less common in the randomized controlled trials than I expected. I do not use tocilizumab in my practice. I think that the evidence supporting it is very flimsy. The recent press release from the REMAP-CAP trial notwithstanding, which is in disagreement with at least 3 or 4 other randomized controlled trials, albeit smaller ones, that have failed to demonstrate benefit of IL-6 inhibitors. It certainly could be that the difference comes down to patient selection. So there may be patients in whom tocilizumab would be beneficial, but we just don't have the data for it. And so it comes down to personal philosophy on adopting experimental therapies. And personally, I err towards the principle of firstly do no harm.
Okay. And in critically ill patients with COVID infection, empiric antimicrobials or antibacterials are usually given. If patients are not improving, do you stop antibacterials if the procalcitonin is less than 0.10 and cultures are negative?
I think that's reasonable to do. The problem is that cultures usually aren't negative because the cultures, particularly airway cultures, are likely to be contaminated. So then it becomes, trying to make a decision based on, again, very non-specific clinical and microbiological information. So often these antibacterials will be continued. I think that if the course of disease is fairly uncomplicated, you have a clear explanation for their clinical deterioration being COVID-19. If there's no clearly evident secondary infection, which certainly would be supported by a low procalcitonin, I think it's very reasonable to stop empiric antimicrobial therapy and just monitor clinically.
Okay, thank you. We have no more questions. I'll give the floor to Dr. Coronel to close the session.
Thank you, Dr. Schwartz. Again, we have learned a lot from you. So to summarize, the most common fungal infection among COVID patients is aspergillosis. And with that, we'll give you your certificate of appreciation, which reads, Certificate of Appreciation being given to Dr. Ilan S. Schwartz, who is the speaker on fungal infections during COVID-19 and given this 42nd Annual Convention of the PSMID signed by the President, Dr. Marisa Alejandria, Dr. Biglor Maginsay as the organizing committee, and Dr. Sino itong isa?
Regina Berba po.
Regina Berba as the scientific chair. Sorry, I cannot read it. Dr. Schwartz, thank you again
You're very
for
welcome.
your invaluable service to the society. Thank you.
Good evening. This is Plenary 13. I'm Dr. Minette Rosario, substituting for Dr. Rose de los Reyes as chair of this last plenary for today. Let me introduce our speaker, whose lecture is on reducing the threat of AMR amidst COVID-19.
Minette, Dr. De los Reyes is already in.
Okay, thank you. I'll exit.
Exit na.
Thank you, Minette.
Exit na. Pati pa ako na-exit. Exit mo na ako.
Okay, let's start the next session. Good evening to all of you, and good morning to our friends outside the Philippines. I am Dr. Marie Rose de los Reyes, and I'm chairing this 13th plenary session, and I think the last plenary session in this convention. So our topic is reducing the threat of antimicrobial resistance amidst COVID-19 pandemic. I would like to say that antimicrobial resistance continues to be a global public health problem. During this pandemic, much remains unknown about how the COVID-19 directly impacts antimicrobial resistance. There are few published data so far among COVID cases found that more than 70% of patients receive antimicrobial treatment, despite the fact that less than 10% of cases have bacterial or fungal co-infection. This increasing use of antimicrobials, particularly the broad-spectrum antimicrobials, may provide opportunity for spread and emergence of resistant pathogens. So during this lecture, we will hear from our speaker how to combat AMR amidst the COVID pandemic. But before I call her to speak, let me properly introduce Dr. Rosanna Piling. Dr. Piling was educated in Canada, but currently lives in the United Kingdom, where she is professor and chair of diagnostics research at the London School of Hygiene and Tropical Medicine, and a founding director of the International Diagnostic Center. She has several appointments in different international committees and had worked for different international agencies, including the World Health Organization. While in WHO, her program and diagnostics research was selected as an example of best practice. She is also a multi-awarded person and the first woman scientist to be awarded the Royal Society of Tropical Medicine's George MacDonald Medal for outstanding contribution to tropical medicine in 2014. So without much further ado, I would like to, it is my honor to present to you Dr. Rosanna Piling. Over to you, Dr. Piling.
Thank you very much. And thank you for the organizers for inviting me to share with you my thoughts on how we can reduce the threat of AMR during the COVID crisis. And first of all, I'd like to congratulate the Society for 50 years of solid achievement in this area. So I'd like to be able to share my slides. So could you see my slides now? Are you able to see my slides?
Not yet, Dr. Piling.
Oh, So I have to share screen. Can you see
Now we're
now?
good. Yes.
Okay, thank you. So what I'd like to do in the next 25 minutes or so is to share with you what is the global crisis of AMR before the pandemic, and then during the pandemic, what has happened, and then how do we move forward? First, the challenges, and then some promises. I think that most of us realize that right now, about 700,000 people die a year due to resistant infections. And that if we don't do anything, by the year 2050, the mortality rates will increase to 10 million, which is more than all the other causes of death, including cancer. And the cost to the global community would exceed $100 trillion. And more importantly, this will push another 28 million people into poverty. And so it's really important that we do something right now about this global crisis. And first of all, there's a lot of overuse of antibiotics in clinical medicine. As fever and respiratory infections are amongst the most common reasons why people seek care. And that in most cases in primary care, presumptive antibiotic treatment is used. There was an audit done in the States where every year about 40 million people are given antibiotics for respiratory issues. And the audit showed that at least 27 million of those antibiotics are not unnecessarily given. And so we hope, and the world has been trying to develop simple rapid diagnostics that can be used to guide appropriate use of antibiotics. And but they need to be usable at primary care and also affordable. And we're not at this stage yet for most of these diagnostics. And at healthcare institutions, similarly, we're seeing increasingly resistant healthcare-associated infections that place a much larger burden on healthcare institutions because it increases morbidity and mortality, increases the length of stay, and also resistant second-line drugs are a lot more expensive than first-line drugs. So healthcare costs also increase. And so here on the slide are some of the more common resistant infections that we are seeing. And diagnostics has a really important role in the prevention and control of healthcare-associated infections in screening so that we could identify patients who harbor these resistant infections from the community before they are admitted to the hospital and for surgery. And then within the healthcare institutions, diagnostics can also be used to identify infected patients and determine their susceptibility to guide their treatment. And then most of all, in healthcare institutions, it's really important to be able to do surveillance for early alerts of outbreaks within these hospitals, and also use surveillance to assess the impact of any interventions that you introduce. In general, there's a lot of misconception about AMR. A study that was done by McCullough showed that in 55,000 people that were surveyed, over 80% of people knew about AMR. So that's really good news. But a large percentage of those actually thought that AMR resistance is related to their bodies rather than antibiotics. And so clinicians are seeing patients in some places asking for higher doses of antibiotics because they said they have become resistant to antibiotics. And so that kind of misconception and led to asking for more antibiotics or higher doses is a very dangerous. There's also a scarcity of teaching materials on AMR in medical schools and nursing schools, and even less on the role of diagnostics, how we could use diagnostics in the AMR response. And in a lot of countries, the laboratory infrastructure, it's really not very well resourced. And so that technologies for the use of diagnostics for either surveillance or clinical care are not available or not affordable. And then there's a lack of AMR data because we cannot be doing susceptibility on every isolate that we can get. And quite often now, we use molecular methods, so there's no isolate to do antibiotic susceptibility. And so we have very little AMR surveillance data in some countries to be able to inform the treatment guidelines and control strategies. And so I think having more robust surveillance data is really important for clinicians to know what should be the first line drugs that would be effective. And then there's been a number of host biomarkers that could be used, such as CRP, such as procalcitonin, but those are the rate of uptake is really low. In France, the rapid strep test is available to every doctor and for free of charge, and yet the uptake rate was only about 30%. And so we need to look into why that is, is it the lack of evidence, confidence in the rapid test? Is it fear of litigation if you didn't use antibiotics to cover? And also, does maybe the testing does not fit into the clinical pathway? And then there's maybe a lack of incentive not to use antibiotics, and patients maybe not want to pay if this is extra to their normal standard of care. And so for all these reasons, we're facing still a really good global crisis, but steadily we're making some headway in each one of these areas. And for our part, what we did was we teamed up with Becton Dickinson Company to make a free massive open online course on the role of diagnostics for AMR. And we developed this course with a lot of experts from WHO, from 15 other countries. And we use case studies and animation from animations based on case studies from every region of the world. The course has now been transcribed into English, French, Spanish, Portuguese, Chinese, and Russian. And all our materials are downloadable for you to use for teaching. The course is divided into 6 weeks, and with the introduction of the global crisis first, and then we talk about the role of diagnostics used in common clinical syndromes, in healthcare-associated infections, and in enteric infections and One Health. And in week 5, we especially feature 2 pathogens that have become almost untreatable: Mycobacterium tuberculosis and Neisseria gonorrhea. And then at the final week, we look at the way forward. Now, this course is actually going on right now. We're into our 5th week, and the link to it is in my slide there below. And I was very pleased to say that this course was first launched in the Philippines and in Indonesia, together with Dr. Regina Berber and her team. And we had very good feedback from all of you who took the course. And so after this run in December, we are going to make this course available at all times on the FutureLearn website. And so we welcome all of you to come and take the course. It's completely flexible. You could just come whenever you have 15, 20 minutes, come and do part of the weekly schedule. And actually all materials from all the weeks are available at all times. So you feel free to come and join at any point. And so these are the specific organisms that we tackle at every week. Now, how has this changed with the AMR crisis? Now, at the very beginning of the AMR crisis, we realized that without diagnostics to confirm clinical suspect cases, we're nowhere with regard to being able to tell people to isolate and to be able to count the cases, track the infections, etc. So the Director General of WHO, Dr. Tedros, had urged countries to test, test, and test. And he says that testing, isolation, and contact tracing should be the backbone of the global pandemic response. And from the very beginning of the outbreak in China, once the sequence of the pathogen that's caused the COVID was known, it was widely shared to allow every country to be able to, and to industry to be able to develop assays to detect the viral RNA. And industry has an unprecedented response in this outbreak. We now see from the Foundation for Innovative New Diagnostics website that there are over 850 tests commercialized, and there are more in the pipeline. And overall, there's over 1,000 types of tests for COVID in the pipeline, commercialized and in the pipeline. And here I show that for molecular tests alone to detect viral RNA to confirm infection, there are over 250 lab assays and over 100 point-of-care or near point-of-care small instruments that you could use for detecting RNA in those people who present with symptoms. You could also use antigen detection tests. There are about 20 lab assays and about 99 rapid diagnostic tests to detect viral proteins. And generally, we have a little bit longer with antigen detection than RNA detection. And then finally, for detection of post-antibodies, we have an overwhelming number of tests, about 390 tests, with over 200 of them being rapid tests. Now, with all these numbers of tests, evaluating how good they are, has been a daunting task. And FINE is doing whatever it can, and different governments are doing, and hopefully they share their data so that we have an idea which ones to use. We also see that the innovation has led to companies coming up with faster molecular detection methods at the point of care. Some of these near point of care instruments can help with the detection in 5 minutes. When you have a positive result, you can call it in 5 minutes. But if for a negative result, you have to wait and at least 23 minutes to call it a negative result. We also have more sensitive rapid antigen tests that could be used for scaling up commercially available testing in communities. And I must say that there is one test that has with it a QR code that you could carry with you on your phone to indicate that you have a negative test by that company. And that because you carry it on your phone, you could show it at border points and at other venues where you need to show that you're negative. There's been, as everybody's waiting for, unprecedented with a faster pace of vaccine development, and that with adaptive clinical trials, companies are able to show data, safety data and efficacy data for fast-tracking regulatory approval. And all this is happening right now, and most countries expect to have some vaccines available for immunization by the end of this year or beginning of next year in the first quarter. And also we've had unprecedented connectivity and surveillance capacity building in terms of testing data, and that we will now very soon have a lot of connectivity with the diagnostic testing so that we could provide real-time tracking of the pandemic in your country to be able to inform where the hotspots are, the true extent of the infection, and evidence-based strategies for control. So, but in order to get accurate control data, it's very important that you choose tests with high performance. And here is an example of what everybody's been able to see. Johns Hopkins University has created a dashboard showing in real time cases around the world where the hotspots are, the number of deaths and the trends. And so in each country, countries also have this kind of dashboard to allow them to track hotspots around the country for contact tracing purposes, to interrupt the chain of transmission, and assessing the effectiveness of containment strategies. And also more connectivity with testing would allow an auto inventory of supplies and diagnostics that are needed for distribution of the test to different areas around the country. And so again, with COVID, there's a lot of effort right now in different countries to try to enhance testing capacity and within healthcare settings, certainly, but also with non-healthcare settings, to be able to get a true picture of what the pandemic looks like in your country. And so besides hospitals, care homes for the elderly, and doctors and offices and nursing stations in remote communities having the ability to test, we're starting to see in many countries pharmacies offering to do testing the similar way to pharmacies offering flu shots during the flu season. We're seeing schools offering testing, workplaces, and also for mass gatherings such as concerts, sports events, and at border crossings. And so these all have to be worked out in terms of how, when you normally have a test that is done with a lot of quality control and assurance at healthcare settings, how the quality of the tests and the testing could be maintained at non-healthcare settings. But all this is being done, and this would certainly help us in terms of AMR. Now, with the with the COVID pandemic response, we've seen in some countries all the advances in terms of reducing the overuse of antibiotics peel back because we see a lot of presumptive use of antibiotics in hospitalized patients receiving that are hospitalized for COVID-19. And this is data from the bulletin of the WHO that was just published last month, that 72% of hospitalized patients in 5 countries show that they receive antibiotics when only 8% of them demonstrated bacterial or fungal co-infection. And in ICU, this is a survey done in 88 countries. 70% of ICU patients receive at least one antibiotic, when 54% of them only had a suspect or proven bacterial infection. And in some countries, azithromycin is often used with hydroxyquinolone, even though neither of them are really recommended outside of clinical trials. And so we really need to be much more careful about use of antibiotics for COVID. In terms of hospitalization, with COVID, there's an increasing number of people admitted to hospital because of shortness of breath and difficulty breathing. And so these increased hospital admissions will increase the risk of healthcare-associated infections. And so it's all the more important to be able to do surveys to know that you haven't got outbreaks of healthcare-associated infections on top of having to cope with the overwhelming burden of COVID infections. And one thing that with this pandemic is that there's wide use of biocidal agents for either environmental uses or personal disinfection. And that could select for resistance and enhance cross resistance to antibiotics, especially for gram-negative bacteria that often would pick up resistant cassettes through plasmids. And so this is a picture presented from the bulletin of the WHO article that I've cited here. Now, there's another article that in general, which will feature a lot of what we need to know in terms of public information that I've also that I've already mentioned before, which is the McCullough survey of misinformation about AMR. And so with COVID, we also have a lot of misinformation, a lot of conspiracy theory about the pandemic. And so it's commonly known we're fighting 2 pandemics. One is the virus and the other is the misinformation pandemic. And we really need to be able to do a better job of public health messaging in order to clear this public misinformation. In terms of education of professionals, I must say that with this, with the COVID pandemic response, all the journal editors have made all COVID publications accessible to everyone, so that it's no longer when you have a subscription to these high impact medical journals that you could see it. Everybody could see all the findings at the same time. And also journals are allowing a lot of gray literature or early results of trials to be shared through journals. And also countries are ramping up their laboratory infrastructure, especially public health laboratories, and private sector laboratories are also being brought in to cope with the testing system in the country and to be able to offer good quality laboratory testing. And then to address the lack of surveillance data, I think with the COVID pandemic response, a lot of countries are ramping up their surveillance data. And so now moving forward, what are some of the challenges and promises? We know that we used to say that we have about 10 years between each major pandemic, but in recent years, we've had, since the MERS-CoV in 2012, we've not had a significant break in number of, in terms of outbreaks of infectious diseases, especially viral infections. And so I've listed the major ones here, but there are lots of others that are happening around the world. But we could see that with almost every outbreak, we need new tests, or we need faster tests, we need more sensitive tests, or more specific tests. And this is going to be maybe the new normal that everybody's talking about, in that we will always be coping with epidemics of one kind or another. And so this is what we need to get used to. And so moving forward, what should we do? Now, in terms of prophylaxis or presumptive use of antibiotics, in this bulletin of the WHO article, the recommendation is that presumptive use of antibiotics should not be, is not recommended for mild cases of COVID unless the patient has underlying conditions. And in that case, the antibiotic use should really be assessed daily for de-escalation. Now, empiric antibiotic use for pneumonia can be considered in the elderly residing in long-term care facilities, as well as in children under 5. And WHO really urged antimicrobial stewardship activities should be integrated into the pandemic response across the border health care system, so that you increase the clinical competence of healthcare workers treating COVID patients, especially in terms of whether antibiotics should be used or not, and to ensure continuity of health services and supplies, reduce the turnaround time of COVID testing. The faster you can do the testing, get the results, the better care the patients can have as to whether they, should be sent home or they should go into isolation, etc. And to exercise caution when use of biocides, and to address gaps in research, including the use of rapid tests for AMR. Now, in another article that's published in The Lancet, the authors, who includes Sally Davis, who's on the Interagency for Controlling of AMR, listed a number of challenges and opportunities. And I selected some opportunities to feature here, which has the intersection between AMR and COVID. And she listed the subsidized hospital AMR surveillance post-COVID. That should be the emphasis of what we should do next, because now that we have more technology and better technology for testing, they should be applied to AMR to increase hospital AMR surveillance, to integrate AMR risk into investment practices for the healthcare system, prioritize antimicrobial stewardship programs, and to be able not only to develop, but to evaluate rapid tests and adopt them widely across primary care. And I must say that we hope that countries not only be able to evaluate how good the rapid tests are, but to facilitate more streamlined and faster regulatory approval and policy development for the implementation of these rapid tests. And that's something that needs to be done. We have seen it done with vaccine approvals and drug approvals for COVID, and surely we could do the same with diagnostics, regulatory approval, and policy development. And most importantly, we need to be able to embrace the One Health approach, because a lot of these outbreaks, the cause of them come from the animals, and to be able to quickly source where the source of outbreak comes from is really important. And we need to develop collaborative public health information campaigns. I think that we've made a lot of gains about how to effectively transmit public health messages. And so that needs to be applied to AMR to make our public health messaging for the AMR global crisis to be a lot more effective. And we need to leverage infection control principles from the COVID experience into AMR for the long term. And so what are some of the things that we could do? We could do a better job now that governments are aware of the critical role that diagnostics play in an effective pandemic response. And so this efficacy for the use of diagnostics in the global crisis for AMR should be applied. So there's a lot of talk. Richard Horton, the editor of The Lancet, has said in one of his talks that we need the governments to have more science literacy in order to be able to understand how to cope with epidemics. And we need to similarly do this for AMR, for many countries. And for the public, we need to increase the awareness and behavior change through effective public health messaging, as I've said before. And the pandemic has really given governments opportunities to be able to hone their skills at public health messaging so that they could mobilize communities to change their attitude and behaviors. And we now similarly can use these skills for AMR. We've seen for the COVID pandemic response, this unprecedented advances in science and technology, not only for vaccines, but also for diagnostics in terms of more rapid and more sensitive and specific molecular and antigen tests for case detection. We also have a number of antibody tests that we could use to look at the true extent of an outbreak in any country, because we know that there are many asymptomatic infections, so that antibody testing is really the only way that we could tell what the true extent of the outbreak is. And if these tests have data connectivity and can be integrated into the lab information systems, then we have a holistic picture of the number of cases in the across the country. We also can scale up diagnostic testing across the communities post-COVID, using the same sort of mechanism that we used during COVID, and actually have a very good robust data from communities as to what's happening. And with that, build early alerts of another outbreak in communities for us to be able to act quickly to interrupt this transmission. And then finally, on the whole, we are seeing that health systems are being strengthened as countries fight the pandemic. And so we see now how we can need to build surge capacity for countries to have more resilient health systems that are adaptable with surge capacity for what's needed for testing, for surveillance, for treatment, and for be able to mobilize vaccinations, etc. And so this whole public health laboratory infrastructure is really needed across many countries, because we always say that nobody is safe until we're all safe. And with that, we all need to have collaboration across within the countries, as well as across different countries globally. So finally, I'd like to close this presentation by saying, with a strengthened public health laboratory and surveillance system in your country, you could start to use real data to provide evidence for public health messaging, for education of the public, the professionals, and to be able to have more effective communication, to be able to have the public be part of the response for AMR, as well as for any other outbreaks that we see post-COVID. And with the good information from surveillance in terms of resistance, susceptibility patterns, etc., you could also have very up-to-date treatment guidelines that you could use, so that clinicians can change their prescribing practices based on these guidelines, and also where tests are available, do testing before treating. And that's something that we really need to work on in terms of making more rapid tests affordable, accurate, and accessible for the AMR crisis. And then healthcare institutions are very, very important. In terms of the AMR crisis, we are seeing that a lot of hospitals have healthcare-associated infections with resistant infections, so that hospitals are becoming in unsafe places that patients are afraid to go to. But where else would you be able to seek care? So it's really important to change that picture now that we have a more well taken care of health facility because of COVID response. We hope that we can now have better response for healthcare associated infections, and also antibiotic stewardship practices within the healthcare institutions and care institutions for the elderly that are especially vulnerable. And then other than human elements in the global AMR crisis, we really need to have the One Health approach with humans, animals, and agriculture and environment monitoring of AMR. And this is something that is, the joint approach is really important in terms of raising awareness, being able to have evidence for good practice and the governance of that. So with that, I'd like to thank you all for listening, and to say that the future is in all of our hands. Thank you very much.
Thank you very much, Dr. Piling. If you have questions, please write them or type them in the chat box or in the Q&A portion here. So I have one question for you from Dr. Buensalido. So it's interesting that culture data is decreasing because of increasing use of molecular testing. Do you see a future without cultures?
I really hope that we will always have culture, because I think it's really important to do antibiotic susceptibility patterns. With molecular testing, although we could detect the genes for resistance, there are a number of circumstances where either the genes are not expressed even when they're there, so we don't know if actually having the gene means that the patient is unable to, the drug is not good for the patient, or that, we only know to detect the genes that we know. We don't, there are a number of resistant genes that we don't know. So culture is always the ultimate weapon that we have in terms of the antimicrobial resistance crisis. And so we hope that in each country, at least culture ability to be able to do culture and also to be able to do susceptibility patterns to inform treatment guidelines are really important. Thank you.
Thank you. Are there any other questions from the audience? We're participating in the Global Point Prevalence Survey. And
Yes.
in the past 3 years, this is prior to COVID, our antibiotic use prevalence survey is about 56%. So that is 1 out of 2 patients that are admitted in the hospital are being given antibiotic, and majority of these are really empirical treatment, as use of diagnostic tests are not, for many reasons, our diagnostic tests, particularly culture, are not often utilized. Do you have information as to the prevalence of antibiotic use in your country?
I actually, I think in the UK, there's been a reduced use of antibiotics, and I think that before COVID, there was a trend to try to, first of all, I think England has been able to reduce the use of antibiotics in agriculture, in farming, by only about 7%, but because of the scale of it, is 7% is quite impressive. And then there's increasing stewardship programs in hospitals, and they are considering certain measures to try to monitor physicians' use of antibiotics. And so these are all coming along. I think that one of the things that, will enable physicians not to presumptively use antibiotics would be use of rapid tests such as CRP, procalcitonin, or any other biomarkers that may be commercially available, together with a clinical algorithm that you could get as an app on your phone. And so Imperial College in London has made such apps for all kinds of infections, and would be useful to think about having these apps, so that once you plug in your rapid test result, and the apps will tell you what's the likelihood that this person would have a bacterial or viral infection. And so that's still the major advance that we need to be able to get, is to get these simple rapid tests to distinguish between bacterial and viral infections to be more affordable. Right now, there are a couple of them that are quite effective, but they're over $20 US each. And so it's not something that you could easily use, but we need to do that. Yeah.
Okay, so thank you very much. I think there are no other questions. Any thoughts on the respiratory panel with SARS-CoV-2 already included, such using the nasal and oropharyngeal swab?
Yeah, I think that those are useful, because I think that you know that normally during flu season, we tell people, if you think you have flu, stay home, don't go out, don't go to your doctor and because you may, actually infect someone if you have the flu, or that if you didn't, you may acquire it from going to the doctor's office to seek care. And so we always say, stay home, don't, so we've never really proactively asked people to get tested for viral infections, because usually there's nothing that you could do. But I think now with COVID, we really need to know, because it's so transmissible. We really need to know whether people have COVID or not. And we need to be able to distinguish, especially during flu season, SARS from flu or other infections, in order to know whether to tell the patient to isolate, self-isolate, and to actually do contact tracing. So I think it's very important. And I think that this is something that hopefully right now there are a couple of companies that have this, but increasingly more companies will have them. We need to be able to do evaluations to know that they are actually very effective in doing so. At least maybe it's another way to rule out viral infections, the major viral infections, in terms of the patient management.
Is it cheaper or more expensive than the RT-PCR, the respiratory panel?
Yeah, it's more expensive, unfortunately. Yeah, but it's quite usable. The ones I know, like the wildfire panel, is very, very good in terms of simplicity of use, because all the reagents are dried onto a pouch, and you just insert the pouch into the machine. And so, but I think that it's really good to have these multiplex panels to use. Thanks.
So for SARS-CoV, how is it compared to the RT-PCR?
You mean a multiplex?
Multiplex.
Yeah, so the multiplex gives you, especially during flu season or in the winter months, when you have more viral infections, different types of viral infections, to be able to pinpoint what the cause of it is, so that you could treat appropriately. I think it's useful rather than just doing the COVID test alone. Yeah.
Another question from Dr. Buensalido. In critical COVID-19 patients who are not yet improving, but procalcitonin is less than 0.10 and cultures are negative, do you stop your antibacterials?
That's a tough one, but I think maybe that will be this would be the call for doing culture, doing more bacterial testing to know what's happening before stopping. Yeah.
Okay, so thank you very much again, Dr. Piling. We have run out of time. And so to close, let me just say that we as stewards of antibiotics, I think there's a need to strengthen our antimicrobial stewardship programs and maybe integrate diagnostic stewardship for faster de-escalation or use of antibiotic. So with that, we end this plenary session, and please stay for the closing ceremony. So thank you, everybody.
Thank you. Thank you.